And we're going to share the screen. And so I'm going to give you Dr. Morales, who's going to say a few words of introduction, and then Dr. Hassan Tariq. You're in, buddy.
Hey, good morning, everybody. So we had an interesting case that required a lot of imaging over a period of about 6 to 9 months. To get a little bit of information and background, I'm going to introduce you to Hassan Tariq. He's going to go over the case presentation. I'll be available for any questions during the case if you have any. Thank you very much.
Hassan, you're on.
All right. Good morning, everyone. I hope you guys are having a good start to the day. Let's get started. So Dr. Morales already mentioned there's a lot of imaging in this case. And what I want you guys to focus on is basically the use of different types of CCTA imaging and how it helped us in the diagnosis of the disease in this patient and how that helped us in the management of it. So let me just put this full screen. All right, so basically this is a patient Dr. Morales saw first, 78-year-old female who presented to the Memorial Hospital with a one-day onset of chest pain, shortness of breath, and decreased appetite. The patient actually had chronic cough for a few years, which was worsening, and the day of the presentation she had basically a bunch of coughing spells, and she felt weak after it, had some retrosternal chest pain, and that eventually led her to come to the hospital. She said it was a tight pain. It was not related to any kind of food or position. She used her nebulizer and oxygen, and that gave her some relief. The pain eventually went away even before she presented, and at the time of presentation she didn't actually have any kind of symptoms. She did have an unintentional weight loss of 20 pounds in the last 6 months before she presented. What's important is her past medical history. You can see she's had a diagnosis of squamous cell carcinoma of the lung, and this was status post left lung resection. She also underwent chemo and radiation therapy. Her last dose was in the December of 2010. She had a left internal jugular and brachiocephalic vein thrombosis that actually occurred in 2013, for which she underwent anticoagulation for a year, and it eventually resolved. She had a pneumonia just 6 months prior to this presentation, and she had some asthma, hyperlipidemia, diabetes, and hypothyroid. So surgery, I already mentioned the left lung resection. She had a hysterectomy. I don't know the reason for this, but that was a long time ago. Family history, there was some coronary artery disease in the family history, but no sudden death or any pacemakers. She was a prior smoker for about 20 years, but she quit a long time ago, and her only allergies were pollen, and she was on glipizide and Januvia, statin, bisoprolol, Advir, omeprazole, levothyroxine, and vitamin D.
You did her chemotherapy?
No, I think for chemotherapy she was on cisplatin, but she only got 2 or 3 doses of it. She wasn't on it for a long time. But from what I understand, she got a full course of radiation therapy that ended in 2010. So for a physical examination, it was pretty much unremarkable, except maybe just on the heart exam you saw that there was a systolic flow murmur. Lungs were slightly coarse on the right and decreased on the left side, which would be consistent with her past history of the lung resection. So when she came to the ER with this atypical kind of chest pain, a cardiac workup was started, which included an EKG that showed only diffuse non-specific STT wave changes. Troponins were mildly elevated at a peak of 0.027. An echo was done, a transthoracic echo at that time, which showed an ejection fraction was reduced and hypokinesis of the basal mid-inferior, basal mid-inferior lateral, basal mid-anterior lateral walls. Atrium was dilated, our PA pressure was a little bit elevated, and so basically the end result from this, or the suspicion, was that she had multivessel disease, and with the mild elevation of troponin and the non-specific changes that she was maybe possibly having an NSTEMI. So going forward, the next step was, actually before I talk about it, she also had some other workup done because of her history of pulmonary complications, and so the chest x-ray that she got showed that there was some early peribronchial infiltrate changes, so there was some suspicion of pneumonia occurring again, and she was started on antibiotics, and some cultures were sent, which later came back negative. So moving on, because of the echo, the next step was to analyze what's going on with the patient's vessels. So what we ended up doing the next morning, was getting a prospective step and shoot CCTA. And so we're in March, and so what happened, this is a low radiation test, a high resolution test, and because you're not really going in there as in a cath or something, it's a non-invasive test. And it's high resolution compared to the other possibilities that you might think of, like a nuclear test. And it gives you very nice images because you can actually take a very good look at the vessels, and you'll actually see that as I go on. So here are the three main vessels. The left circumflex is the one we're really concerned with because, as you can see, it has a proximal lesion, a high-grade lesion, and also a distal, basically 100% occlusion. What you also see is an LAD, and LAD has this, proximally has this narrowing, which is not so severe, but there is a narrowing here, maybe less than 25%. The right coronary, on the other hand, seems to be just patent without any kind of disease. And so that's what we actually saw. While we were doing this, we also scanned around and we looked at the aorta because we're always concerned about what approach is going to be taken and how does the aorta look in that sense. So here you can see the aortic arch, and you actually see this kind of just deformity attached to the wall, and it seems like it could be, I mean, an artifact, a dissection flap, or something else, or it could be something more severe as like a thrombus or like an atheromatous plaque. And so, I mean, just the way it looks, I think there was some concern. Just here you see it from a different view. It's actually even protruding a little bit into the lumen. And once again, another view, you see some calcium here. So there's definitely, the patient has some atherosclerosis happening in the aorta. And you have this kind of, and this was just distal to the subclavian, left subclavian. So this finding was pointed out to the interventional cardiologist because we knew the patient was going to end up going to cath for the left circumflex lesion. And so they were asked what should be done, how should you do the cath. At first they were thinking that it's just like an artifact, but when they looked at the different images, they were shown these images, they were a bit more concerned about an atheroma. So they decided that maybe instead of taking a femoral approach up the aorta where there's a chance that you might come across this and you might end up disrupting this, maybe a more radial approach would be taken so that you come across and kind of bypass this completely, come from this side, go down, and then take a look at the vessels. And that's what was done. So here you see the left circumflex that I showed you in our CCTA, and then this is what you see in the cath. And you see there's like a proximal lesion, not well seen because it's kind of hidden, and you see this complete occlusion. And so the next step that was done is basically they did angioplasty and stenting. A big stent was passed through so that both of these lesions were encompassed and they were opened up. And the flow, it was semi-grade flow 3 once they were done with this. So here you see the LAD, and there's not much disease in the LAD that you see here. There may be a little bit of narrowing, but it's kind of hard to see here. You have the right coronary, which seems angiographically normal even with the cath. So our CCTA did the job of the same job that the cath would have done. The LAD again with the proximal lesion, not so severe, and it's actually this vessel up here. So not this one, this is the circumflex. So you can see there's a little bit of narrowing, not too much, but there is something there. So after the cath, basically the patient had a complicated course. There was some wheezing, rash, and the patient went into respiratory failure. It was thought that it's the result of the contrast dye because you got the dye for the CCTA and then for the cath itself. So for that, she was intubated for a day. After that, she was extubated. She was fine. She was sent home on aspirin for life, Plavix because of the stents put in, and also pravastatin. Vascular surgery was also talked to about what to do about this aortic atheroma, and they said, well, they need more imaging to get a better idea of what it really is. And so they said maybe it's an artifact or a dissection and so on. So they just needed more questions to be answered. which basically after the patient went out, came back and saw us, we said, okay, let's do maybe an MRI, aortography to get an idea of what it looks like. So now we're in April, and it should play. No. There you go. Well, that's playing. Yeah, let me just take another look at it. Well, this is supposed to be moving, but it's not, so sorry about that. But you can actually, the only thing you can see here is that there's myocardial thinning. This is very close to when the patient actually had the heart attack. There's no scar here. This is late gadolinium enhancement. So that was a good thing. We thought it was viable myocardium and it was recovering. And even though at this point there was some wall motion abnormality, overall, later on, what I want to tell you guys is that it actually did come back. So here you see the aortic thrombus. Here you actually see the aorta again. This is the defect we saw when we did the CCTA. This is the MRA, and you can actually see this very mobile kind of mass moving. And yeah, it's moving, and it's actually all the way in the lumen. So this actually raised the concern that maybe the patient, while they have an atheroma, they have a thrombus which is overlying this plaque. And so that got us really concerned about what to do next. Here's another look at it. So you can see from our CCTA what it looks like. And it's actually a little bit more disguised here. It's hard to see, but you see some movement here that's actually going on, which is different from the just the blood flow. So that then brought us to the question what to do about this. So we know the patient has an aortic atheromatous plaque, which is commonly seen in elderly or coronary artery disease patients. The problem with this is that it can lead to systemic embolization, which can happen either spontaneously or as a result of some procedure that the patient might have where you disrupt the lesion, like a cath. Some of the risk factors, we already talked about some mechanical interventions. Other things are having a very, very big size lesion, something that's mobile, something that's protruding or it's pedunculated. Also the location matters in terms of the patient having a stroke. More common if it's a ascending or an arch plaque than it is if it's a descending plaque. So what do you do about it? So you can start a single antiplatelet therapy or warfarin therapy. There were studies done to look at dual antiplatelet therapy, and they said it's no better than using a single antiplatelet therapy. And there were also studies done. The most recent one was, I think, ARCH, and that one looked at comparing whether dual antiplatelet is better than warfarin. I think in a follow-up of about 3.4 years, what they came across was that there wasn't really, I mean, the antiplatelet seemed to be doing better, but the study was not powered and it didn't have enough recruitment, so it was not really that conclusive. It was just more so hypothesis generating. A statin is also needed on top of this antiplatelet, and so either statin with aspirin or statin with Plavix is a thought. The other big question that comes is triple antithrombotic therapy. Why? Because this patient has a thrombosis, so he has an indication for anticoagulation. On top of the dual antiplatelet, because the patient recently had the percutaneous coronary intervention with the stenting. So this actually is seen in patients who might have indications with anticoagulant. Other most common reasons would be an AFib, which would need a long-term anticoagulation. Other causes may be a recent PE, a DVT, and in our case, you have this patient with a complex aortic plaque. So the evidence out there, this is back when we're talking April, the evidence is fairly weak, and most of this is basically relied on expert opinion. What is recommended was 2 antiplatelet agents, like an aspirin and a Plavix is what's recommended. And you either use warfarin or you use one of the novel agents, the non-vitamin K antagonists. And these are some of the different doses which is agreed upon. You can see there's a lower dose here also, and many experts actually end up using the lower dose because they are concerned about major bleeding. As you already know, the novel agents have not really been tested in some of these situations, and so it's actually not recommended in patients which have mechanical bioprosthetic valves. The plan for our patient was that basically he has a mobile thrombus on top of a plaque. So we said he's going to need the dual antiplatelet, but we need to add an anticoagulation. So we decided on Eliquis at the lower dose of 2.5. and we switched to a high intensity statin, which was Crestor at 20. So the patient was followed up, and after 6 months he came back, and at that time we decided that we need to do some more imaging, get a better idea of what's actually happening with him. So this time we actually decided to go with a different type of CCTA. This is the retrospective or helical gated CCTA. Why we decided for a different one was basically we were more concerned about motion. We said this patient has this thrombus. We have been treating this thrombus on top of the plaque, and we want to know how the patient did on his medical therapy so far, and whether we actually made a difference on his thrombus, and whether it is still just out there, just hanging there, whether he needs what to do next step. So we thought we would go with something that would give us high resolution images, which would still be non-invasive, which would give us better images than we did with the MRI, and it would also give us some motion so that we can get the same information as the MRI. So we did this test, and here you see some still images from it, and you can see the right coronary still looks widely patent. The left circumflex has this stent in place, and you can actually see the lumen in between, so it's a very nice image where you can see the lumen in between. And then we looked at the LAD, and this was surprising because we had this lesion which was not severe, the proximal lesion, the less than 25%, and now if you look at it, it seems the lumen is much more narrowed. And so this was really concerning to us, that despite the dual antiplatelet, despite the patient being on medication for the risk factors, his LAD really progressed. So here's again a comparison of what it looked like in March. Not so bad. In January, it actually progressed. So the patient ended up getting a cath for this, and here you see the LAD, and you see the severe narrowing proximal. And the right coronary looks patent like it did before. The left circumflex has this stent, so it looks widely patent here. Here you see the LAD again in the back. You can see the narrowing. So the LAD before, and then it was stented. And then we looked at the aorta again and just compared it in our new study compared to the old study. So again, you can see here, this is a still image. This is all the information that you can get out from the prospective CCTA, a still image. And it looks like a lesion which has some component. And here you actually see a movie. Now I cannot get this movie to play again for some reason, but here it is from a different view. Anyways, you see that movie, and I'll show it to you in a different view, but I guess even this is not working. I don't know.
Over to here, or...
There we go. This one is working. I can switch over, but
That's fine.
so this actually, even the one before, this was moving all over in there. You can see it flapping all over in the lumen. And in this image also, you see it moving all over in the lumen. And the same thing was happening here. So basically, we were able to get video which showed us that you have this plaque which is moving now. So again, it confirms that there is a big thrombus there. I think it was measured out that the whole lesion is like 9 millimeters. You have this big thrombus here which is still moving in there. And so this was really concerning. Again, with the approach, it was, I think, the radial approach which was taken to fix the LAD. And this is also really concerning. We came across this new thing which we didn't discover before. This was actually in the superior vena cava, and you see this lesion which is hanging here. Again, this is supposed to be a movie. I don't know why this is not playing, but you see this lesion, it's hanging here, and it's actually moving. It was actually moving back and forth, down and up. And you see this lesion again here in a different view. And again, this was just kind of moving all the way around, just going like this. And so, again, this raised the concern that this is a thrombus here in the superior vena cava, which we were not able to see previously. And so, moving forward, the patient, as I mentioned, ended up getting a cath. So the patient was sent to Tampa General, and at the time he was getting that, they did not actually have our CCTA images, the movie images. So what they ended up doing was like a TEE, and so in this TEE again, they looked at the SVC thrombus, and I don't know why all these videos are not playing. So anyways, they did a TEE, And when we compared it to our retrospective gated study, which was supposed to show motion in January, you see motion here, and the TE itself showed this lesion which was protruding into the lumen, and even that one showed motion. So we got the same information as the TEE. So the TE wasn't really needed, but that's what was done. And the next question that came after that was, what do you do about this now? Do you undergo medical or surgical therapy? I'll pull it up on this, we have time. So basically the IR and the vascular surgeons were consulted, and basically what they said was that the patient actually has a lot of calcium. This is a chronic plaque, both in the aorta and in this SVC. So the chances of it embolizing are not as high. And so what they said was that maybe we'll go with a more conservative approach with just medical therapy. So what medical therapy do you go with? Do you just continue with the triple therapy that we have? So then this is, this study came out in December. And so this study, the Pioneer Atrial Fibrillation PCI trial, and this actually had some different recommendations from the ones before that we were following. So they looked at 2,124 non-valvular AFib patients who underwent PCI with stenting, and they assigned them to 3 different arms randomly. One was rivaroxaban at 15 QD with a PGY12 inhibitor like a Plavix, and they did that for a year. Then they did rivaroxaban at a very low dose of 2.5, and they combined it with dual antiplatelet, and they looked at different time periods like 1, 6, or 12 months. And they also looked at it with the standard therapy of warfarin with dual antiplatelet, again looking at different treatment arms. And from the study, what they were able to find was group 1 and 2 actually had lower rates of significant bleeding than compared to the standard therapy with warfarin, the group 3. Also, what they found was that the rates of death from cardiovascular causes, MI or stroke, were similar in all the groups. And there was no significant differences between groups 1 and groups 2 in terms of which one did better. So whether you go with dual antithrombotic therapy, just 2 drugs, 1 antiplatelet and 1 anticoagulant, or whether you go with 2 antiplatelets and 1 anticoagulant, you don't really still have an answer, and you don't really have an answer about what to do in terms of the duration of therapy. With that in mind, the next question that we also some of the ongoing trials that we are looking forward to see if they can better answer the questions is some of these trials like Augustus, Rejewel, and the Entrust. And they are looking at some of the other novel agents, the dabigatran or apixaban or edoxaban, to see how they compare to warfarin or some of the other standard therapy in terms of just a second. I think it's yeah, look for him. Here, I've got it muted. Okay. Sorry about that. Just give me a second. Okay. All right. So these are the ongoing trials that will help us answer the question of what to do with these patients that need anticoagulation and dual antiplatelet, or just antiplatelet therapy because they had a recent stent. So from this, the next question was what to do with our patients. So what was decided was, again, dual antithrombotic, which would include 1 antiplatelet and 1 anticoagulant. So we decided with the Plavix at 75. The patient was already on Eliquis, so we increased the Eliquis from 2.5 to 5 milligrams. And so the questions which I've already kind of talked about, why switch to dual antiplatelet? Because there's new data now with the Pioneer AF-PCI trial that suggests that you can just do with 2 antithrombotic agents. You don't need all 3. And why apixaban? That's more so like an expert opinion kind of thing. We just used apixaban because Dr. Morales felt that was a good choice for this patient, and she was previously also on it. What would be really interesting to see is how some of the new trials pan out and how the trial with the apixaban, the INTRUST trial, will do. So that's what was done with the patient. And so that brings us to some of the references that you can look at to look at some of the guidelines which are already out there and what's up and coming. This I actually wanted to show you because, of course, there's the question of what happened with the SVC thrombus. What happened? Did we see it previously or not? So these are the previous studies. We have the Prospective CCTA that was done in March. And here you see this kind of defect. And this, the only thing is this is like a still image. So you can't really tell if there's any motion to it, whether this is just a mixing artifact or something like that. You can't tell just from a still image. So it was hard for us to say, well, maybe this is a thrombus or maybe it's just an artifact. So that's why it was kind of unclear. The MRI itself did not show like a clear image. I'll go through these images again in the slide to show you some of the videos that we have. I'm going to try and see if I can play them on a different computer. But you see again, it wasn't clear whether there was anything there. So that's why it was sort of missed. And I just have these images just to show you again what.
So just as a side reference here, what's helpful about gating a cardiac CT versus step and shoot, which is a prospective, which is basically one slice volume. Here there was some concern whether or not, whenever you see a CTA and you see a vague defect in the appendage, as you can see here, a left atrial appendage, you're never really quite sure 100% whether that's just poor mixing, because sometimes when you get a contrast, you get this big left atrium, and the contrast has a little difficult time completely mixing at the tip of the appendage, and you're not sure if this is just poor mixing, which is stagnant red blood cells that have not been filled with contrast versus a true thrombus. This is a nice example where actually gating the study can kind of give you a little bit more information. And so if this was truly a mixing artifact, then what you would expect is swirling. And what you see here is you see a mobile element in the left atrial appendage that's swinging back and forth consistent with a true thrombus. And then just to kind of pause it here, these are the kind of things that you see in the superior vena cava all the time. You see dark swirling things, and you're never quite sure if that's a thrombus. So here you can see if we pause it at any kind of level, this could appear as a thrombus. So you never really quite feel strongly about calling anything in the superior vena cava with a stagnant image. And you can see where this area that could be a thrombus, once you gate it and move it, you can see the swirling, which is consistent with poor mixing and mixing of blood, etc. And this patient actually had a papilloma in this tricuspid valve, which is another interesting finding. So kind of going over just in some detail about the differences between retrospective helical scanning. What you're doing is you're basically you're overlapping data on top of itself. The patient is continuously moving, and you're acquiring data on top of itself in sort of a helix pattern. And then what you're doing is you're going back, well, I guess I don't have the other images. So if you go, you're taking all this data, and if you take an R to R cycle, do you have that in there?
Yeah, I have it on this one.
Okay, so if you take an R to R cycle right here, you're going to collect data from the very beginning all the way to the end. And that's the difference between retrospective and then prospective. So in prospective, you're only capturing data at one point in the cardiac cycle. And so if you take this R to R cycle to this R to R cycle, and you divide it into tens per se, this would be 0, 10, 20, 30, 40, 50, 60, 70, 75, 80, 85, 90, 100, right? And so diastasis, which is 75%, is where the heart tends to be the stillest. And so this is where we usually capture our data on prospective imaging. And retrospective imaging, we capture the data across the entire R to R cycle. So we're able to play a continuous movie and loop it back and forth across this R to R cycle. The obvious advantages of going from retrospective, which is this, to this, is your reduction in dose goes down significantly. This would be anywhere from 15 to 18 millisieverts of radiation versus 3 to 4 millisieverts of radiation. And just to kind of give you some kind of background information on how much radiation goes into what kind of study. Here's a typical PA and lateral chest x-ray giving you about 0.1 millisieverts. A calcium score gives you about 1 millisievert. Just annual background radiation, just being on Earth, gives you about 4.5 millisieverts. If you live in Colorado, that goes up to about 8 millisieverts in a year. And so there's, you know, depending on which type of imaging, a standard diagnostic cath, somewhere about 7 millisieverts. But if you perform intervention, PCI, that goes up to about 17 millisieverts. A standard nuclear stress test gives you anywhere from 12 to 24 millisieverts depending on which agent you're using, whether it's thallium, dual isotope, etc. And so just to kind of give you some more information as to where, and then we're gonna move back so you can see some of these other pictures.
Let me change you to presenter.
Okay.
Okay, Alberto here. Okay, presenter, yes. Yes. And you're unmuted. Yes. Okay. There you go.
Am I unmuted? Yes.
Yes.
All right. I think.
CVD.
Can you hear me? Check the speaker.
Here.
All right. Can you hear me?
Yes.
All right.
I'll do that.
Okay. So let me go back to our, this one. There you go. So here you can actually see our initial prospective CCTA showed this atheroma, and here you see it, the mobile mass is kind of moving in the lumen when you did the MRA. Here you actually see it from another angle, the atheroma from the same CCTA, and you see this kind of mass, which is this density, which is just moving back and forth in the lumen. Here again is the same lesion from before and the CCTA we did later on, which shows us motion, and you can actually see it clearly, very nicely, much more so than the MRI, how it's just moving around in the lumen. And here's another angle, you can see it just move right there. And this you already saw, so you can see them move from the different views, what it looks like. And here's the SVC thrombus. This is what we initially could not pick out because there were still images, but if you look at this one, as we keep moving through this heart cycle, you can see that it shows up and it is actually just moving. And from a different angle, you can again see it just kind of dangling in there in the lumen. And yeah.
And you can see, so this would be an axial view where you're looking sort of from the top of the head looking downward, and you can see here's the superior vena cava, here's the left atrium, here's the aorta, you can even see the coronary artery right here, and the pulmonary artery coming down this way. And so you can see this vague defect that if you had only a stagnant image would look like a mixing artifact. It'd be very difficult to appreciate that. But with imaging, with the motion, I mean, you can see how clear definition, you can see LV contractility, you can see the valves open, you can see the left coronary artery, you can even see the left circumflex stent right here in motion, the left atrial appendage, pulmonary arteries, and then you can see this defect that's dark with bright components within it, which is consistent with calcification, which is a chronic process. This is an old thrombus that has sort of extended downward into the superior vena cava and extending at the level of the atrial isthmus area right here at this junction right here, extending down near the right atrium. You can even see the tricuspid valve opening and closing nicely here. And so the concern is obviously this is, and we looked at our old CT and it looked like it was extending a little bit further than it was previously. So our concern was obviously, is this impending something significant. So remember, this lady has only one lung, and so she only has one pulmonary artery. This is the residual, if you can see here, this is the left pulmonary artery that has been essentially excised. As you come up here, here's the pulmonary artery, and then we're going to make our way up, hopefully here shortly. As it continues, there's a pulmonary valve, and then here we go, we're going up, coming up, and you can see that the left pulmonary artery is actually excised right here where this scar tissue is. So she only has one pulmonary artery, and it's this one. So if this were to detach, you know, it would be a pretty significant massive thrombus in the pulmonary artery, in the right pulmonary artery, and it would almost certainly be lethal. So we had a lot of things dealing with this patient. A possible impending thromboembolic pulmonary event that would potentially be lethal, a very tight proximal LAD, and then this curvilinear aortic mobile thrombus. So this is something that needed to be dealt with on a multi-specialty level, and we decided to admit her to the hospital, put her on heparin, have multiple specialists see her. We did have interventional radiology and cardiology and vascular surgery involved. And at the end, in conclusion, basically the decision was to treat her conservatively, to try to suck out this chronic old calcified thrombus with an angiojet or a penumbra or whatever you may have. It would be a very high risky procedure that almost inevitably could lead to potential devastation. So the thought was just treat her medically on a different regimen. There was discussion about putting her on anticoagulation with Coumadin. However, the patient was very adamant she did not want to be put on that. We did discuss with hematology and vascular surgeon, and their opinion was really no difference between Eliquis or Coumadin. So we decided instead to increase the dose of the Eliquis from 2.5 twice a day to 5 milligrams twice a day. And our plan would be to re-image her in about 6 months and kind of get more information. So, do we have any questions from the audience?
Yeah, does she have recurrent squamous cell carcinoma?
So the question was, does she have recurrent squamous cell carcinoma? And I think she's had a PET not too long ago, as well as obviously all these multiple chest CTs, and she was evaluated by her by hematology oncology that do not feel that she's had recurrence, and that these thrombotic events were probably old thrombus. She did have a jugular venous thrombus that we were told resolved, but you know, I think that whole innominate vein is thrombosed. I have other pictures, and you can see extensive collaterals of venous around her chest area. So this is a chronic process, and I think this thrombus never resolved and has continued to extend. And she's someone that just needs to be on lifelong anticoagulation therapy. And there's no direct evidence that she has recurrence. She does have a weight loss history, so you know, there's always the inevitable. But I think she's followed up with her hematologist, oncologist, and so far she's still in remission. So we'll go with that for now.
Does she have a coagulopathy?
No. There was a workup done for hypercoagulability also by a hematologist, and for the patient, she does not have a hypercoagulability disorder.
Should she receive anti-inflammatory therapy because of the rapid progression of the LAD lesion?
So she was initially put on, I think she was on a low dose of simvastatin, 10 milligrams. We had switched her when we found the aortic atheroma to Crestor, and I think she was initially on 5. That was later increased to 10, and then when we had the sequential last CTA that showed not only that there was persistence of the aortic atheroma and mobile thrombus, as well as the other findings of progression of the LAD, we upped her Crestor from 10 to 20 milligrams daily, which is probably the, you know, there's some studies that high intensity statins will actually in certain scenarios reduce progression, and actually may even reduce you know, intimal narrowing of vessels. So there may be some regression. There's some data showing regression of atherosclerosis in mostly the soft and non-calcified plaques. So that, yeah, that was done with a statin. I don't know of, I know that there's some other data showing some other agents, especially with the PCSK9 inhibitors, showing significant reduction in atheroma burden, but she would not be a candidate at this time until outcomes data is introduced, hopefully in the upcoming ACC meeting. So these new PCSK9 inhibitors are able to significantly reduce your LDL down to the low 30s, but in addition to that, there's data showing that there's regression, significant regression of atherosclerosis. And we have hopeful news that in the coming months we'll have significant outcomes data showing that there's reduction in stroke, reduction in heart attacks, reduction in deaths, which is similar data to what we have with Crestor, but hopefully it will be even more significant and more powerful. That will hopefully have a change in the guidelines.
Do you have an MRI of the brain? See if she's having any emboli.
I believe she did have one. I don't know if it was at Tampa General, and I don't know if she has one as of recent. But I did advise her to follow up with her cancer doctor regarding, you know, all these new findings, the weight loss, etc. She was evaluated by hematology oncology at Tampa General, but these are not her oncologists. So she's going to schedule an appointment to follow up with her oncologist and get more information.
If she had recurrent stroke, despite medical management, would you do an endarterectomy of the descending aorta or transverse aortic arch?
Yeah, that's a great question. I think if she were to have an event related to that aortic mural atheroma with thrombus, the nice thing is that it is past the left subclavian artery. It would be doubtful that it would go retrograde and up the branch vessels into the brain and cause a stroke. I think if she were to have an event related to the, as you can see here, here's her her plaque right here and her thrombus, and this is the left subclavian. Then you got the carotid, and then you got the brachiocephalic. So it's beyond that. So if she were to have an event, it would probably be a distal event, probably either in the gut or in the lower extremities. But definitely, if she has an event, that would be an indication for some sort of interventional procedure. Again, this is a frail little 81-year-old lady who only has one lung. She's on chronic oxygen, and I don't think very many people want to do anything aggressive with her at this point. But yeah, that would be a strong indication for some sort of surgical intervention procedure.
So is that site where the thrombus is in the aorta, is that at the ligamentum arteriosum? Is there a remnant there that created that?
It's possible. That is near the location. That is exactly right. You know, when we look at it in different views, there is atheroma at that area, but you know, that is the same location. You know. But it's clearly an atheroma that's become complex. And if you think about a coronary artery, acute coronary syndrome, I mean, that's exactly what this is. This is a acute syndrome of the aorta where you have an atheroma where the cap, you know, sort of erodes or breaks apart, and then you get a thrombus that forms. Well, if that happens in the coronary artery, you get a thrombus in a coronary artery, you get acute heart attack. Well, this is a huge vessel, so you're not going to fill up the entire aorta. You're just going to have a big thrombus sitting there, and in certain scenarios, it stays there, and it could break off, it could solidify, and so you try to target all your therapy to try to prevent that from happening. But very similar scenario with acute coronary syndrome. It's just an acute aortic syndrome of the aorta involving an atheroma.
Does she have chronic D-dimer elevation?
You know, interesting. I don't recall looking at that, but yeah, certainly she would fit someone that would have multiple reasons to have a chronically elevated D-dimer. I don't recall. Do you recall looking at her labs? Yeah. I don't know if that was done, but I'm certain that she would probably be someone that would fit the criteria for a chronically elevated D-dimer, where you're consuming certain factors for sure.
So the fact she had the TE just is a failure for us to be able to interconnect data, which is unfortunate because of the HIPAA laws and blah, blah, blah. We said, hey, this is great. We have all these EMRs and we can interconnect everything. And then Congress passes a law that says we can't connect anything, right?
I agree. So it's unfortunate she ended up having multiple other studies that were duplicated. Here's the TEE, though. We do have nice pictures, and you can see that superior vena cava, this bright thing showing some calcium, and this mobile component extending into the cavo-atrial junction right here. And then it's just another angled view showing the same thing. And then here is the sort of the CT gated showing this mobile thing, and then you can see this mobile thrombus in the aortic arch just distal to the subclavian as you scroll back.
Oh, that's very pretty. And there's no indication of any chronic dissection from what you see in the aorta?
No indication of dissection. The thought initially with a still image that this could be either thrombus or a dissection. My initial concern was more that this was a dissection just because of the way it looked. And so we raised that concern to the interventional team because her initial presentation was acute coronary syndrome, even though it was very vague symptoms, very mildly elevated troponin, but their wall motion abnormalities were there. So, and she certainly had some bronchitic changes, etc., and she was treated for bronchitis. But the main concern was what would be the best approach based on this vague defect at the lesser curvature of the proximal descending aorta or distal aortic arch, and it was decided to do a radial approach versus a traditional transfemoral approach to avoid this area. And then later we came to the conclusion that indeed it was a thrombus, not a dissection. So
if she did have a lot of, say, distal embolization to the distal circulation, kidneys, legs, whatever, blue toe, would it be consideration for endovascular stenting in that particular area?
Yeah, that's a great question to ask the vascular surgeons. I don't know if the location, just being so close to the arch vessels I think you have to have a certain amount of distance between arch vessels or great vessels to be able to put a sleeve or a stent within something, and then obviously the risk of the procedure itself. And then is it even still there if the patient has already embolized that thrombus? Would you even need to do that if it's already been embolized and there's no persistence there? And then in that case, it would be just continue medical management of that area to prevent recurrent thrombus. Certainly, you would have to do interventional therapy for the area of concern at the time of embolization, whether it be a lower extremity or a splanchnic artery, and that would be either endovascular or surgical, depending on the scenario. But she is well versed on the possible scenarios of all of these scenarios. She's been she has a very good family source, and they have a physician in the family, and so they're very educated, and she's got good social support at home. So hopefully none of these things happen, in medical therapy hopefully takes care of the good majority of it, and she develops no further complications.
Well, that's a superb workup. We're very pleased to have a critical mass of advanced cardiac imagers with Dr. Morales here. Thank you very much for being our guest today, and Dr. Tariq has done a bang-up job with this presentation. It's very complex imaging. He hasn't even started his residency yet, and he's just embraced advanced cardiac imaging in his future career. And so we really appreciate the input he's given. We appreciate these superb images with the correlations. this would be a great case to present in any conference. Certainly, it would be a good one to show at the Florida ACC chapter meeting, because they always invite a presentation of a brief, very interesting, complicated case, and I would nominate this one for sure. So thanks a lot, guys. We appreciate it. We're going to be posting this online at cardiaccarecritique.com as a recorded video, and so we had a great time with this case. Thank you.
Thank you. Thank you for having me.
Thank you very much.
Is it muted?